All right, well, welcome. This is a very dangerous place to be because you've all had lunch, I suspect. And my record is 36 seconds to loss of consciousness. So if you're gonna, Louise is going 25. If you're gonna pass out, try not to hit anybody and try not to, get whiplash. And drooling is always a little problematic. I'd like this to be as I'm going to start my motor here. I'd like this to be as open as possible. So if you have a burning question, ask it, and I may say, I'll get to that in a few minutes, or I'll say, let's talk afterward. But if you have a question, I'm happy to try and answer it. I'd rather you get your questions answered than go out of here saying, what the hell was he talking about? So, and some of this, maybe a lot of this is going to be redundant. If you heard Ed Sickles talk this morning, I thought he did a great job, and Mark Helvey, I thought everyone did a great job, but a lot of the concepts that they brought up, I'm going to bring up again and hopefully clarify, or you'll just go, here we go again, I have to listen to this junk. I think this is very important, though. If you really stop and think about what we do, we would not have really good reason to exist as a subspecialty if we weren't screening. Because if women are coming in symptomatic with lumps, you can put a needle in a lump actually for less money than it does to do an ultrasound. And if it's a cyst, you drain it and it goes away. And if it's solid, you get tissue and you can make the diagnosis. So imaging really devolves, I think that's a word, from early detection. So screening is very important. I'm not saying that from a financial point of view. I'm just saying from a practical point of view, everything we do is pretty much determined by whether we're looking for early breast cancer or not. This slide is up here just because I'm an angry, bitter old man. I've been doing this for a long time, as you can tell. And it's the same thing. We have the same arguments. They just repackage them and send them out again. So I apologize. Again, it's probably my loss of frontal control. But if I come out a little angry and hostile, it's because I am. But I will try not to be too severe, but maybe not. Anyhow, if you really look at the data, mammography screening, what you do is one of the major medical advances of the past 50 years, and I'd be happy to be challenged on that. The death rate, as I'll show you and as you heard this morning, is down by over 40%, primarily due to screening. Therapy has gotten better, but therapy works when you downstage or downsize cancers. There's been no impact on women who present with metastatic breast cancer. All the therapy in the world may delay death, but unfortunately those women are going to die from their breast cancers. So the way that we save lives is to find breast cancer earlier. And just in case you either do become unconscious or I don't get to it, I never did this before, but I'm going to summarize what I'm going to tell you before I tell you. That's the way they teach you how to lecture. Tell them what you're going to tell them, and then tell them what you told them. I've never done that, but I'm going to try it. So, lesson number one, there's little, if any, overdiagnosis of invasive breast cancer. And most of what I'm going to be saying, I'm going to touch a little bit on DCIS. There are issues about DCIS, there's no question about that. So let's keep DCIS off the table for now. There's little, if any, overdiagnosis of invasive breast cancer. No one has ever seen an invasive breast cancer, unless someone's going to make a liar, and I dare you to make a liar out of me. No one has ever seen an invasive breast cancer detected by mammography that disappeared on its own. Has anyone seen it? Let the record show, and I've done this with like thousands of audience members, no one raised his or her hand, her or his hand. Screening and your doctors will say, oh, well, screening doesn't reduce the rate of advanced cancers. It absolutely does. False positives, as I said obnoxiously this morning, is a misnomer. These are not false. It's a name that's given by biostatisticians and epidemiologists, I think, to just scare people. We're calling people back for a few extra pictures or an ultrasound for the most part and telling them they don't have breast cancer. I was taught that a false positive is when you tell someone they have breast cancer and they don't. The only harm, and I hate the term harm, again, I think that's been chosen to be pejorative. The only harm that's affected by delaying screening are recalls. If there is overdiagnosis, as you heard this morning, they don't go away, so they're going to be there at 50 if you didn't find them at 47 or 42. They'll still be there at 50. So you do nothing about overdiagnosis by delaying screening. And of course, overtreatment goes with overdiagnosis. Screening is the main reason that deaths have declined. Therapy saves lives when breast cancers are treated earlier. Now, immediately as I get talking, you'll say, well, why are people doing this? And the answer is I have no clue. But, and this is a brilliant observation of mine, it's probably about the money. Can't be sure. Can't be sure. It's very hard to track down, for example, anyone from Dartmouth here? The Dartmouth Institute for Health Policy and Clinical Practice is funded somehow, but it's very hard to find out where all their funding comes from. And they're one of the main opponents of breast cancer screening. And then there are other people, well, there are other issues. So Gilbert Welch, who was at Dartmouth until he plagiarized his last article and left, sorry, it's true, wrote an article where he basically said, why are we making insurance companies cover breast cancer screening when it doesn't work? And I forgot, I've got to find that, you can go online and find quotes like this: as our society debates whether to continue to require insurance companies to pay for mammograms. Why are doctors worried about insurance companies? I don't know, maybe they're just, they feel bad for these poor insurance companies, but there may be something else going on. Another possible issue, again, I feel bad talking about this because I don't have the facts, but I keep asking myself over and over again, why are people doing this? Now, some of it maybe they just don't understand. I mean, most of it is actually fairly obvious that they're making it up, but they keep doing it. So either they're not understanding or there's some malicious intent. One of the major opponents of screening who's published from Europe is a part of the International Prevention Research Institute, and if you go on their website, down the gray, this, I don't know if you can see it from where you're sitting. I think I bring up another picture here, let's see. Yeah, these are just a few of the supporters of the International Prevention Research Institute. It's a who's who of big pharma. Again, I'm casting aspersions without any proof, but I'm trying to understand why this keeps going on. And of course, why would big pharma care? Well, they probably make more money if breast cancers are larger and later stage. We're not alone, actually. The folks who were working with cervical cancer screening had to face the same thing back in the 70s, where they started saying, why are we doing cervical cancer screening? There's never been a randomized controlled trial of Pap testing. I think it was in Iceland, though, where they did cervical cancer screening. The death rate from cervical cancer went down. They stopped screening. The death rate came back up again, and they started screening again, and it went down again. That's pretty good evidence that it was probably due to Pap testing. But, it's Iceland. Who knows? Yeah. Anyone here from Iceland? I've got to be careful. They had similar arguments about overdiagnosis and overtreatment. What you find when you are around long enough, and you can tell I've been around too long, is the fact that they recycle the arguments. So these were arguments for cervical cancer screening. Now they've said, well, we didn't do so well with that. Let's try breast cancer screening. And my favorite is, experts can look at the same information and come to different conclusions. Let's agree to disagree. And this is a picture from the Cape. And to me, the Earth looks flat in that picture. Am I missing something? So clearly, there's a discussion about this business that the Earth is a sphere. It's ridiculous. You can look right there and it's flat. And it's almost that, I wouldn't even say trivial, that ridiculous, that we're having people look at the same data and coming to different conclusions. They're not. They're making up a lot of the data. And I'll take you through that as we go along. The bottom line is the facts are that randomized controlled trials, which, by the way, are the only way you can prove a benefit from just about any medical intervention. You divide a large group of people randomly into two groups, So everyone in one group has a twin, essentially, in the other group. And if you find the cancer in twin A before it becomes successfully metastatic, and twin B goes on to metastasize and it kills her, you'll find that there were fewer deaths in the screen group than the control group. And if you have enough fewer deaths so that it's statistically significant, then you can say that because the only difference between the two groups was screening, that screening is why the death rate has gone down. There's no other way of doing it that everyone will accept. So we as a group of breast imagers have always argued from science, and the randomized control trials have proven, here are the data, you saw this kind of, this is a very difficult place to use a mouse, almost impossible. This kind of plot where everything to the left of the vertical, if the 95% confidence interval, which is this bar, is all to the left of the vertical, that's a statistically significant result. And these are the data from the randomized control trials showing that there's a statistically significant mortality reduction. And the trials are designed specifically with a group in mind. So what's caused problems, and I don't have time to go into the details, is when people have said, well, this trial, like the HIP study, was for women 40 to 64. Let's look at women 40 to 49. Well, if you want to do subgroup analysis, you have to plan up front. So you have enough women in the 40 to 49-year age group so that if they do have fewer deaths, it can be statistically significant. Because otherwise, if it's mathematically not possible, then you'll say, oh, well, 40 to 49, it wasn't statistically significant, there's no benefit. And that's what happened. We wrote a paper showing that people were asking for things of the trials that were mathematically impossible, and they still did it, and they made decisions based on it. But anyhow, if you look at the trials, the way they were designed, the statistically significant benefit, and then they broke women out 40 to 49 early on in the trials when there was no statistical power to do that, and they said, oh, see, there's a benefit, but it's not statistically significant. We shouldn't be screening women in their 40s. And that's when I started losing my hair and growing. You can't do that. And I'm a dumb radiologist, for crying out loud, and these are epidemiologists and biostatisticians who are saying, oh, yeah, we can do it. Well, you're really not supposed to do it, but we're going to do it anyhow. And that's what's happened. I mean, it's that crazy. So with longer follow-up down at the bottom here, let's see if I can move this over. So down at the bottom, statistically significant mortality reduction for screening women in their 40s. I would point out to you that the Canadian study had more deaths in their screening group, and that was one of the alternative facts that we dealt with before many of you were born, where the Canadians, sorry, how many Canadians? Come on, you can admit it. My daughter-in-law is Canadian. The Canadians were saying, oh, we're killing women in their 40s. Really, they said that. Then they finally said, well, I guess not. The other thing is, as I think it was Ed who was saying, randomized controlled trials underestimate the benefit due to contamination and noncompliance. Noncompliance is you invite someone to be screened and they say, no thanks. If they die from breast cancer, they're counted as having been screened. This drives my wife nuts every time I talk about this. So why would you count them? You have to. Similarly, in the control arm, if a woman goes out and gets a mammogram and has her life saved by it, she's an unscreened control. So the randomized control trials don't give you an accurate overall measure, but the fact that they're statistically significant given all the contamination and noncompliance that goes on in these trials, because there's a lot, it's statistically significant. The absolute number, again, as Ed or Mark was saying, take that number with a grain of salt, because they're trials of invitation to be screened, not trials of actually being screened. And you saw this morning, again, our Canadian colleagues who did a terrific study in the provinces. These are called observational data because they're not a randomized controlled trial. They just looked at women who had access or got screened compared to women who didn't. Now, there's all kinds of potential biases in there because maybe the women who don't get screened have a sense that they're going to have a bad cancer and they don't even want to know about it. They don't get screened for whatever reason. And so that could imbalance the studies. The observational studies, and there's just a handful, these are the handful, of observational studies show that when women have access to breast cancer screening, their survival is much better, their mortality goes down. Observational studies are not proof. They're frosting on the cake. The only proof of benefit is from randomized controlled trials. We're not going to have any more randomized controlled trials, so we have to use the ones that told us that there is a benefit from finding breast cancer earlier, and then rely on the observational studies to show that, in fact, when you go out into the community, the benefit continues, and it's not just in a randomized controlled trial. You saw this, Ed Sickles, I think, showed a very similar slide, where in the U.S., the death rate from breast cancer was a flat line, a lot of waves in it, but yeah, good Kopans, flat line. No, it was a wavy horizontal line, that's better, horizontal line. With maybe even going up a little bit, as I'll show you in a minute. Mammography screening began in the mid-1980s, and the death rate began to fall in 1990. And it's, you heard, continued to go down. Ed Hendrick, physicist that is part of our organization, as well as the American College of Radiology. Jay Baker, you all know, and Mark Helvey, you heard this morning, did this kind of nice analysis of the SEER data, Surveillance Epidemiology and End Results. That's our national database. And they looked at the data in SEER, which started in 1975, and it's hard to tell, was this a flat line? Was it going up? Was it going down just a little bit? So they did an analysis depending upon what you decided the baseline here was. And depending upon what that baseline was, you saved a range of lives, but it's essentially about a 40% reduction in deaths, and again, you heard this morning, since 1990. Again, a horizontal line going back to probably 1940, if you use the Connecticut Tumor Registry, which goes back to 1940. No change in deaths until screening came in. Better treatment, no question about it. But I think, again, treatment saves lives when you have earlier detection. And that's what all those observational studies showed. Presumably all those women in the observational studies had access to treatment. But the ones who fared better, and I'll show you in a more recent study that, again, was shown this morning, the women who had their cancers detected earlier by screening did better than the ones who didn't. There have been therapeutic advances, no question about that. But the death rate declines primarily among women who have been screened. This is the study, again, that was mentioned this morning by Tabar and colleagues. Over 50,000 women who were followed for, it was actually more than 39 years. And what they found was that the women who participated in screening had 60% lower incidence of death. This takes away from survival. They just looked at the death rate at various times after screening, and 60% lower at 10 years and 47% lower at 20 years. So this is what happens when you introduce screening into the general population as opposed to in a randomized controlled trial. You know, I keep going back and forth. I think therapy has made a big difference. I mean, a big difference, because they get to treat cancers earlier. When you get to treat cancers earlier, your therapy is more successful. But if you look at men, you know, we get breast cancers, fortunately not as many as women do. The death rate from breast cancer for men in 1990 went up. In women, it started to come down. It stayed up for, I think it was around 2003, 2005, and then came back down to 1990 levels. And it's been there. Now, theoretically, you treat male breast cancer the same as female breast cancer with the similar outcomes. So clearly, unless these men aren't being treated, but I think most of them get treated, what's the difference between what's gone on with women and what's gone on with men? And I would suggest that women get screened and men don't. So actually, I think it was Murray. Is Murray in the audience? Murray Rebner, I think, was the one who first pointed that out to me. We hardly ever talk about male breast cancer, but I think it's instructive that early detection is probably the reason that the death rates go down. Now, again, what most people don't realize, and again, you heard this morning, all of the groups agree that you save the most lives screening starting at 40. That's what we really heard if you were able to sort through a lot of the data that was given to you. And they all admit that you save the most lives. The U.S. Preventive Services Task Force admits it. The ACS admits it. The American College of Physicians admit it. They were the ones who started this back in 2007. And you've heard about the CISNET models, and you saw this slide. See, it's good because I got the other guys to give my talk, so then you can go to sleep and you won't miss anything. But you save the most lives by, this is ACS, sorry, I have to change that. This was ACS before they went soft. One of my friends was on the panel, the ACS panel. Again, they didn't have any experts in screening, and I think there was one breast surgeon on the ACS panel. What is being done now is to have panels that know nothing so that the advisory groups can advise them and have them come to the right conclusions. And I say that cynically, but if you look at who advises these people and the conclusions they come to, they're clearly all swayed by the advisory panels and not by their own experience, because they have no experience. And I like to point out, this would be like having me decide neurosurgical guidelines. I can read the literature like anyone else, but I don't think you want me deciding neurosurgical guidelines. It's become a bad thing to be an expert, which I find offensive for one thing and stupid for another. What's the point of having expertise if you say, oh, well, anybody can figure this out? So it's unfortunate, but that's what's gone on. The task force said you should have access to screening starting at 40. The ACS said start at 40. Again, you heard this morning. Experts were excluded from the panels. The arguments against screening became subjective, and they were the biases of the panel members. As you heard this morning, the ACS qualified waiting until 45, because 40 to 44, they said, was a qualified recommendation, and it was based on what we think women would want. What? I mean, who are these people that are deciding they know what women, I don't want to have breast cancer. Does that mean I don't have to be screened? I don't want breast cancer. I mean, it really is this crazy, and yet it gets disguised in a lot of data and analytical jargon, and you miss the point that they just decided, well, we think women can't handle it coming back in their 40s. When they hit 50, who cares? The old bats, it doesn't matter. But 40 to 49, we need to have shared decision making. I mean, it's astonishing, and maybe I'm missing something, because I seem to be the one who's most astonished. I'm hoping you'll leave here astonished. Not that they let that guy talk again, but that can you believe what's going on? And the answer is, I can't believe what's going on, and it keeps going on. So the whole business was on overdiagnosis, overtreatment, and false positives, which I'll come back to. As I asked Dr. Miglioretti, how many fewer recalls are equivalent to having one woman die unnecessary or an avoidable death? And no one's ever answered that. It takes 1,900 women to be screened to save one life. All right, so what does that mean? Well, we think that's too many women. Really? How'd you decide that? And then they go through all these hoops. And Dr. Miglioretti is a terrific person. I mean, she's written some very nice stuff. But at some point, we've got to stand up and say, enough is enough. Even if you're a biostatistician, just because someone says, well, I want you to break it down 40 to 49 and 50 and over, the question should be why? There are absolutely no data that support using the age of 50 as a threshold for screening. None. Zip, zilch, as my high school teacher used to say. So again, all the CISNET models, which all the groups relied on, show you save the most lives by annual screening starting at the age of 40. 40,000 women still die in the United States every year from breast cancer. So we're interested, and I hope you're not, we're not sitting back on our laurels and saying, oh, we've done our stuff. 40%, that's good enough. 40,000 women still die every year from breast cancer. And the question was why? And the problem is that our national database, Surveillance Epidemiology and End Results, SEER database, incredibly, even though we've been arguing this for 40 plus years, doesn't keep track of how breast cancers are detected in the United States. If we had those data, we wouldn't have, you'll see some of the things that have been written that are just nuts wouldn't have occurred because we'd actually have data, but we don't. So how do we know why 40,000 women are still dying? Well, this is a study we did in the Harvard Teaching Hospital, so you know it's accurate. But I think we did a good job. We looked at women who died from breast cancer. So there's no overdiagnosis involved here. They died from breast cancer. And 71% of the women who died from breast cancer were among the 20% of women who weren't participating in screening. Now, there's two lessons here. First of all, just because we find a breast cancer by screening doesn't mean we save a life. So again, we shouldn't be sitting on our laurels. My frustration is how hard it is to get better at what we do. It took 20 years to develop digital breast tomosynthesis. It's crazy, just moving a tube through an arm, 20 years. And I know because I did it and lived through it. The point is, it shouldn't take that long to advance our ability to find breast cancers. The problem is we're still fighting about the old stuff. Well, maybe it doesn't matter that you find breast cancer earlier. It matters, and let's get over it and figure out how to do it while you're trying to figure out how to cure breast cancers. I might point out, not particularly successfully. Let's try and find better ways to find them early. I support everything. But the point is, if this is the experience in the Harvard hospitals, I suspect that many of the 40,000 women who die each year were not participating in screening. We wouldn't have saved them all, there's no question about that, but we might. And the problem is I can't prove that because we don't know how breast cancers are detected in the United States. Okay, so just bottom line, if you're still conscious, most of you are. I'm impressed. The fundamental scientific evidence shows that the most lives are saved by annual screening starting at the age of 40, period. Everyone agrees with that. It's incredible to me that people say, but let's wait until 45, or but let's wait until 50, and let's do it every 2 years. And it's all pretty much made up. Breast cancer, and you saw the incidence curves, which I thought was fascinating. The most recent incidence curves show that it's low for teenagers, fortunately, and in their 20s. We see breast cancers in their 20s. Starts to go up in their 30s, and then it's almost a straight line ascent for women 40 and over. And I would point out, nothing magical happens at 40 either. It just so happens that that was the young age that the randomized controlled trials included. But when in the old days, anybody remember getting baselines at 35? Oh, it's a lot of old people in the audience, so that's good. We used to get baselines at age 35, and actually at Sloan Kettering, they screened women 35 to 39, and the cancer detection rate for women 35 to 39 was the same as 40 to 44. So there's nothing magical about 40, but we've successfully preserved access to screening by sticking with the science, and the science is 40 to 74. And that's why, we go to the mat for 40 to 74, and then the rest is we think this is good and we think that is, but we don't have the absolute proof. But breast cancer is not a trivial problem for women in their 40s. Who was it? It's the head of the U.S. Preventive Services Task Force, who will remain nameless, who said, well, breast cancer is not really a problem until women are 50 and over. Hello? I guess 30,000, not a big deal. And I think you saw these data in terms of, these are from the American Cancer Society analysis, where they were looking at years of life lost to breast cancer. And you can see for 40 to 44, it's about the same as 50 to 59. And 45 to 49 is more than 50 to 59. And I always like to combine stuff. So here are the combined data. And you can always fiddle around when you group data. I'm the biggest arguer against grouping data. But just to make this a little more dramatic, there are more years of life lost to breast cancer for women 40 to 45, that's this red bar that I added them together, compared to women 50 to 59. So everyone's, we don't have to worry about it for women in their 40s. Yeah, except more years of life are lost to breast cancer among women in their 40s, and you're saying, wait until 50. Again, this stuff makes no sense. So you got to wonder what's been going on, because the data, just are overwhelming in support of screening women starting at the age of 40. Annual versus every 2 years is tricky, but I think Mark gave some great arguments as to why annual is better. And the so-called Harvard study that we did was a computer analysis, and just showed and it's not surprising, the more frequently you screen, because you're hoping to catch cancers at a small size before they become successfully metastatic, the more frequently you screen, the more likely you're going to catch some of those cancers earlier. So as he pointed out, I think he said screening every 6 months was better than every year. That's what our analysis showed. I think we went as low as 3 months, which would have been even better. But don't start pushing 3 months. We need it annually, and we'll be happy there. So many of you think that alternative facts is a new concept. Kellyanne Conway, is that who came up with it? Oh, you were wondering where you heard that before. I pay attention. We had these long before she was anywhere. We've had alternative facts in breast imaging for decades. Now, Becky Zerbier, who's trained at Mass General and head of breast imaging. Becky's not here, is she? She's the head of breast imaging at Dartmouth. Talk about being in the beehive. That's where the Dartmouth Institute for Health Policy and Clinical Care, the major anti-screening group in the world, is located, and she's running breast imaging at Dartmouth, trying to preserve annual screening starting at 40. Talk about a project. But every time another paper would come out, she would go write to me, and then she finally said, "This is like whack-a-mole." You guys know what whack-a-mole? Whack-a-mole's the arcade game where I think it's a prairie dog pops up and you hit it with a hammer, and another one pops up from another hole and you hit that one with a hammer, and then so you're constantly. I used to think of it more as driving behind a pickup. I don't know where I got this. I was running behind a pickup truck through a dry cornfield, and they were throwing Molotov cocktails out the back, and we were trying to put the fires out. But whack-a-mole, I think, is better, not quite as violent as I was thinking. But it's exactly that. I actually wrote a paper called The Arcade Approach to Breast Cancer Screening, and talked about all the moles that have been whacked. So I'm going to just go through a few of them here just to give you a flavor. And this is a truncated version. You'll be unconscious by the end of this, I'm sure of that, but just to let you know, this is just the highlights of the moles. So initially, back in the 50s, even before I was involved, and into the 60s, it was thought that breast cancer was systemic before you could find it, and so there was no point in finding it earlier. The randomized controlled trials whacked that one. Then, we can't possibly screen all the women in the United States 40 and older, and there was a big study called the Breast Cancer Detection Demonstration Project. If you want to know if someone knows what she or he is talking about in breast cancer screening, if they can say BCDDP, you know that they know what they're talking about. Try it, it's not so easy. Anyhow, BCDDP showed we could screen. They screened over 250,000 women over a 5-year period, did a great job. Radiation from the mammogram was going to cause more cancers than would be cured. This was a guy named Baylor at the time from Harvard. He was wrong. His analysis was way out of line, and many, many more analyses have been done showing that the radiation risk from mammography is probably non-existent because the radiation risk, even at high doses, drops off for women as they age, so that by age 40 there's no measurable risk. All the risks are extrapolated from lower doses, and even the extrapolated risks are so low that any benefit outweighs any of those risks. So when you keep worrying about, tomosynthesis is higher dose, it actually isn't, because the companies, much to my disappointment, cut back on the dose for their 2D mammograms so that the dose of 2D plus tomo would not be much more than what was being used, say, 10 years ago as an acceptable dose for mammography. So even if you do a full field digital plus tomos, the dose is still well within reasonable limits. And you can probably, again, the breast is resistant to radiation once it has matured. No benefit from screening women ages 40 to 49. Again, that got whacked. The parameters of screening change abruptly at the age of 50. I was trying to find out from Dr. Miglioretti why we're choosing 50. What people say, well, the cancer detection rate changes at age 50. Well, there was a study that showed that. It went from 2 cancers per 1,000 to 10 cancers per 1,000. Now, the author of the study did something that I thought was a little sneaky. She looked at the cancer detection rate for women 30 That's at 3, 30 to 49. And compared it to women 50 to, I think it was 80, 79. Now, first of all, when you do a dichotomous analysis, just look at two numbers, in a constantly increasing variable, you're going to weight the analysis based on the highest and the lowest numbers. So why did she include 30 to 39? We weren't talking about that. Well, it brought down the number to 2 per 1,000, and it made it look like suddenly at age 50 it jumped to 10 per 1,000. It didn't jump. It was a steady increase, just as the prior probability of breast cancer steadily increases in the population. It doesn't suddenly jump at age 50. And again, that was the reason for my nasty question to Dr. Miglioretti. Oh yeah, again, the Canadians, nice people. Again, my daughter-in-law, the head of the Canadian National Breast Screening Study, it used to be the National Breast Screening Study of Canada, now it's the Canadian National Breast Screening Study, claimed that they had more deaths in their screened women in their 40s than in the control women. And he said, well, maybe mammography is squeezing cancer cells into the blood and causing metastatic disease and killing women early. And this was front page news. I mean, again, this is when the hair started falling out. It's not true. The reason they had more deaths in their screened group was they put more women who were destined to die in their screened group. And I'm happy to talk to anyone who wants to go into details about the Canadian study. It's so damaged that it shouldn't be used in any analysis. But one of the things they did a clinical breast exam on all the women before they put them in one group or the other. And then the people who were assigning them, probably completely innocently, could put a woman in whatever group she wanted. So if someone had a lump, no one's ever been able to interview the coordinators, but the coordinator could say, well, I want to make sure she gets a mammogram, because this is the first randomized controlled trial they were ever involved in. So she could have put them in the screening arm. And they clearly, one way or another, imbalanced the trial. There were not more deaths, certainly not due to mammography. Then the NCI in 1993 said you have to have a benefit within 5 years. That just completely ignores the fact that you can't expect a benefit within 5 years when you do a periodic screen. That's fundamental epidemiology. They ignored that. Breast tissues are dense prior to the age of 50, hiding most cancers. I love this one. The breast turns to fat at 50. Now, any of you who are close to 50, be careful, because you could be walking down the street and suddenly... These are arguments that were made. Again, not much, we already talked about this, not much breast cancer women in their 40s. Age creep, my favorite. This was a phrase coined by one of the opponents of screening, because they claimed that the benefit for screening women in the trials that was showing up for younger women was because they hit age 50, and I guess suddenly screening started to work. You can't make this stuff up. And then they went back and looked carefully at the data. Well, it turns out that wasn't true either, but it took, 2 or 3 years, and I don't know how many papers that we tried to get published. Some of them got published. I think I got one published, that this was just sheer nonsense. And it's sheer nonsense. Consensus Development Conference said there's no benefit from screening women in their 40s, having just heard a day and a half of statistically significant mortality reduction for women in their 40s. Oh yeah, but we didn't use those data. Excuse me, that's why you were convened. No answer. Again, another nonsense conclusion that was whacked. Then in 2000, Gacci and Olson, Gacci's a famous guy now in our group, you should know the name. He and Welch have been the main people who have argued against screening. Gacci just got finally fired from the Cochrane collaboration for doing bad stuff, but did a lot of harm. Gacci and Olson said there was no benefit for screening anyone. It got into the Lancet. It got us all crazy, so they gave him another shot. They gave him a do-over. I've never heard of this in medical publishing. They let him do it over, and he wrote the same paper in 2001, and the Lancet published it against peer review. Peer reviewers came out in public and said, this shouldn't have been published. Lancet said, well, we wanted to do a little controversy. Oh, thanks. So no benefit for screening anyone. Anyhow, there's a benefit. The reduced use of hormones had an effect. That's nonsense. Screening women in their 40s should be based on their risk of developing breast cancer. There's absolutely no, the randomized control trials, and this is true if I don't get to all the slides today, they should be, you should have access to them. But the people who are deciding guidelines have somewhat legitimately said we're only going to use randomized control trials to decide our guidelines. And then they go ahead and say, well, we don't think average women in their 40s should be screened, but absolutely let's screen high-risk women. Not additional screening. Don't screen the average risk women, and we'll just do mammograms in the high-risk women. Well, there is zero data to prove that screening high-risk women will save any lives. I mean, we think it will, and it should, but there's no data. The randomized control trials did not group women by risk. So people who are out there, we're only going to go by randomized control trials, but high-risk women should be the only ones screened in their 40s. It's sheer nonsense. The other point is that most women who develop breast cancer, and I think one of the questions, or somebody asked me at lunch today about essentially screening based on risk. And the problem is we don't know who's going to get breast cancer, and we don't know who's not going to get breast cancer. And the major risk factors that we do know about, genetic predisposition, family history, atypical biopsies, account for about 25% of breast cancers each year. If you do the math, that means that 75% of women who are diagnosed with breast cancer each year have none of the known risks. So if we only screen high-risk women, 75% of the women who are going to be diagnosed with breast cancer won't have access to screening. People don't say it. You're going to hear a lot about the effort to screen only high-risk women because there are more cancers in high-risk women than in low-risk women. There are more per number of women, but there are way more women who are not low risk, but average risk. The volume and the number of women at average risk is enormous. So there are many, many more cancers. Now, and if I don't get to say this, if you want to say, well, it's too expensive, we don't want to pay for it, I'm all for that. Come on out and say it. I suspect that there would be a little bit of an argument, it's not worth saving our lives. But it's a reasonable discussion. They know they would lose it. The bad people out there who are trying to reduce access to screening, they know they'd lose the argument. So they come up with nonsense. The U.S. Preventive Services Task Force was prevented from looking at cost benefit. So what did they use? Number needed to screen. What is the number needed to screen a measure of? Cost. Does anyone in this audience care that you'd have to screen 1,000 women to save your life? I don't think so. Maybe there's some of you who are very economics conscious. But I suspect most of us would say, is that all? Anyhow, these are all the stealth, I call them now stealth arguments that are coming out there. Overdiagnosis. We already answered this question. No one in this audience, and no audience that I've ever spoken to or with, has ever seen an invasive breast cancer disappear on a mammogram. Doesn't happen. Now, there have been invasive cancers that have disappeared. They're all palpable. They're all clinically evident cancers, and there are a handful. The opponents like to say, this happens every day. No, it doesn't. They're so infrequent, they're actually miracles. And unfortunately, in some of the women whose breast cancer disappeared, their metastatic disease killed them. So the argument is really specious and nonsense. And if you're going to say, breast cancers can disappear, stop treating clinically evident cancers, because they're the ones that can disappear. I mean, there's no consistency in all this. Since mammography doesn't find the fastest growing cancers, it's not very useful. That's not true. It may not find the fastest growing cancers. We don't save lives probably before 5 years. So someone who's got a really fast-growing cancer that's going to kill her in 2 years probably won't benefit from screening unless we get better screening tests, which would be nice. But dying at 5 years and 6 and 10 and 15 is still dying prematurely. So that argument really frosts me as well. Again, massive overdiagnosis. I'm going to go through this and explain why that's nonsense. The management of DCIS is a legitimate area of disagreement. I've gone back and forth on this. I think DCIS is clearly the precursor lesion for invasive cancer. They start inside the duct. So one cell at least has to be DCIS before the second cell becomes invasive. But it's almost certain that they're the precursor lesion. The problem is we don't know how long any given lesion, and there are different kinds of DCIS, will stay in the duct, and when and why do they invade and then become potentially lethal. But I'm staying away from, we can talk about DCIS afterward if you want, but I'm staying away from that. Money could be saved by allowing women to die from breast cancer. You know, the one paper that tried this got hammered. Mark Helvey, just incredibly good at what he does, came back and pointed out, well, you forgot to point out that for all women, losing a woman prematurely is a $250,000 loss to society. And if you're younger, you're even worth more, $1.4 million if you're in your 40s. This study didn't take that into account at all. And it's $250,000 last year of life that you have to account. So this didn't account for any of the actual benefits of not dying prematurely. Screening data are outdated. Again, modern observational studies support that. Screening doesn't work because it did not reduce all-cause mortality in the randomized controlled trials. And the answer to that is you can't reduce all-cause mortality in a screening trial unless you have about 2.5 million women in the trial, and I'll try and get to that in a few minutes. Advanced cancers have declined. Screening's old-fashioned. Well, I would say it's old-fashioned, although I'd be a little upset that I thought tomosynthesis was fairly modern, and MRI, you know, could save almost everyone if we can figure out how to do it less expensively, and people are working on that. And, oops, sorry, let's see if I can go back. And we've gotten better at screening almost on a decade-by-decade basis, higher resolution, better at finding cancers. Watch out for value-based screening. Value-based screening is just another way of saying we want to ration it. Oh, let's just do things that are worth it. You know, it's, well, I think you have to spend some money to save lives. I think it's close. I mean, no one's ever done a really good recent cost-benefit analysis. Karen Linford years ago did a study that showed that screening, I think it was $25,000 per year of life saved, which was well within, at that time it was, I think, you had to be under 50,000 or something like that. I don't know what I think you have to be under 100,000 per year of life saved. I haven't seen a good analysis. It may cost a little money to save more lives, but that hasn't been shown either. Okay, so the harms of screening. False positives. This is the one that should frost us all. It's a false positive is a test where you're called back for additional evaluation and you are found to not have breast cancer. So the test was a false positive. The problem is that I think most people, including I would suspect many primary care doctors who don't give it much thought, think, oh, well, that means that she was told it's not real cancer. No, it's a recall from screening, period. That's what is called a false positive. And these are just sort of general data. I think your practices are probably similar. The percent of women who are recalled and who get extra views, and about 2% of women screened are urged to have a image-guided needle biopsy, and about 20 to 40% of those are cancer. People say, oh, that's way too many biopsies. Well, before we were doing imaging and surgeons were doing excisional biopsies for palpable abnormalities, the yield of cancer was about 15%. So we're actually doing much better, and our cancers are smaller. That's not to say, oh, just go biopsying everyone, but again, I think these are just made-up ideas to try and reduce access to screening. The major medical journals have, this is really a major scandal. I'll give you the biggest one. You know the Journal of the National Cancer Institute? We all know that's the National Cancer Institute's journal, right? Hands up. National Cancer Institute? Yeah, don't be nervous. It's the Journal of the National Cancer Institute. Whose journal is it? The National Cancer Institute. Well, you know, actually it isn't. It's actually Oxford University Press's journal that they call, because they bought the title, the Journal of the National Cancer Institute. If you go on their website, way down at the bottom of a whole long list of stuff, it says, I'm not sure if I put it in here. No, I didn't put it in. It says that the Journal of the National Cancer Institute has no connection to the National Cancer Institute. Now, I don't know much about publishing, but that seems to me to be one of the biggest scams I've ever heard of in medical publishing history. Hate to use words like that, but again, my frontal atrophy is catching up. I mean, this is outrageous, because papers get picked up from the JNCI as if they have the imprimatur of the NCI, and they don't. And the media spread them around, and the JNCI, under their previous editor, would not publish, because I know I had a bunch of them turned down, and other people did too, would not publish any papers supporting screening, particularly women in their 40s. And the same is true at the Annals of Internal Medicine, and JAMA, and my institution's journal, the New England Journal of Medicine. If you go and look at their now it's changing, they have new editors. But if you go, I think pre-2015 at least, I don't think you can find a paper in any of those journals that supported breast cancer screening, certainly for women in their 40s. They're all negative. So false positives and overdiagnosis. So why are we being faulted for overdiagnosis and overtreatment? Have any of you diagnosed a breast cancer? You go, this is a 5, I think it's a, but you haven't said, you got breast cancer. I've never made it, and 40 years, I've never made a diagnosis of breast cancer. And I've certainly never treated one. And yet, we're being faulted. It's your fault for overdiagnosis and overtreatment. And of course, it's ridiculous. It's the pathologists who make the decision about diagnosis and the oncologists who treat. And I've made the point that what's being done with screening is like blaming the engines in our cars for accidents. Get rid of the engines, you won't have any accidents. Well, it's true. Stop screening, you won't have any overdiagnosis. Well, that's probably not true. And again, the only harm that can be reduced is false positives. And again, that's a misnomer. Cancers do not disappear, as I've already said, and yet these panels, one of the arguments is wait until 50, because all the cancers that you would have found from 40 to 49 will disappear, and you won't have as much overdiagnosis. They don't disappear. They will, and they're real cancers. I mean, I feel silly even talking about this, because they're real cancers. They're not going anywhere. And they will be there at age 50, and they will be there if you screen every 2 years, the same fake cancers, which don't exist, but the fake cancers that they want us to think are there, will still be there. So it's nonsense to say. So the reason that they want to delay screening and let women die, as simple as that, is to reduce recall rates. And again, if I were a woman, I'm outraged, I'm not a woman, I'd be, what are you deciding for me that I can't handle the anxiety of being called back for a couple of extra pictures or ultrasound, or even a breast? We've all done breast biopsies. It's never hurt me, but that was supposed to be funny. Sorry. I know you're losing it. We're almost done. You're almost out of here. No, we know it's not fun. But my wife, and she said I can say this, had 2 back in the days before he had needle biopsies, had 2 surgical excisions, fortunately for benign problems, and went back to work the same day. You know, if I had said to her, now, dear, you need to, I don't want you to be too anxious, she would kill me. She would have killed me. So, again, the miraculously disappearing cancers are all clinically evidence. It's hypocrisy to say, don't screen, because we don't find the disappearing cancers. It's the clinical ones that are disappearing. Okay, let me just, getting to the end here. Oh, so I want to just quickly take you through how this nonsense about overdiagnosis has come up. This was the Blyer and Welch paper that, interestingly enough, had an op-ed piece by Welch right after it came out. I mean, the coordination with the media are astonishing. Just a quick anecdote, which is sad, but it's important. The Dartmouth Institute for Health Policy, apparently there was an obituary of a physician from Dartmouth, a woman who died in her, I think it was her 54, in the obituary it said from cancer. And then in the obituary it said, and she had been helping to run training programs for the media to educate them on the problems with screening. And, there was the whole obituary was nicely complimentary about all her work. And I looked and I said, well, she had cancer. What kind of cancer did she have? Not in the obituary. It turns out, I was able to find out, she died of breast cancer. So this is a woman who was arguing, don't get screened, so I don't know, but theoretically she wasn't participating in screening, who had a breast cancer in her 40s that killed her in her 50s. And nothing said in the obituary. And I actually wrote to the Boston Globe and said, don't you think that's newsworthy? And they didn't do anything about it. So there's a lot of media. I think the media have been trained to not think that screening is particularly useful. This New England Journal paper that said massive overdiagnosis, number one, they said it was due to mammography screening. They had no data on who got mammograms and which cancers were found by mammography. I've never seen a legitimate paper, that was critical of an intervention with no data on the intervention. It was pretty remarkable. They combined DCIS with small invasive cancers. The paper relied on assumptions, estimates, extrapolations, and they actually said guesses. It's in the paper. We guessed that this is what would happen if there had been no screening. So just a quick basic information. This is the incidence of breast cancer before screening. You do screening, everybody comes in, let's say they all come in the same year, you get a big bump because all the cancers have been building up that you could have found but you didn't, and then the ones that you would have found that year, and then the ones that you found earlier because of screening. So you get what's called a prevalence peak. This is well described. And then as you continue screening, the rate comes back down, and now you just have the new cancers that are coming in that keep you above the baseline. So this is what normally happens if you had a well-orchestrated screening program. Now, if the baseline was increasing, in other words, there were more cancers in the population before there was any screening, then the baseline is tilted. That's actually what happened in the US. Here are the SEER data, and the SEER started in 1974. Actually, it wasn't just the president's wife who had breast cancer, but the vice president's wife was diagnosed with breast cancer same year. So there's a little blip because women went out and got screened and then they stopped being screened. And then screening began around here, where you can see this sudden jump in incidence. Well, it's actually the prevalence screen. Now in the US, we didn't start getting mammograms right away. It wasn't like everybody started screening in 1985. It started at 1987, about 20 to 30% of women, as far as we can tell. We have lousy data. And it went up over time, and then it plateaued around 1999, where about 70% of women said that they had had a mammogram in the last 2 years. That's as close as we can get to data. So what people missed is that this is one large prevalence peak, because more and more women are participating, and then it starts coming back down toward the baseline. Well, where's the baseline? So what Blyer and Welch did was they said, well, we're going to use this as the baseline and we'll extend it out. So they said that this is what they thought, what they guessed the rate of invasive breast cancer would have been in 2008, which is the year that they measured it. So it's down here. The actual numbers are the dots, the SEER data. So clearly, these must be fake cancers because they never would have happened. Well, if that's correct, then that's correct. Oh, that didn't work out so well. So if this really was what the baseline would have been, and this is what the actual numbers of cancers were, then these are fake cancers. I would agree with that. But where did they get this baseline? Because in fact, for many, many years, going back to 1940, the incidence of invasive breast cancer in the United States was going up steadily. Why? Well, it had to do with women maturing earlier. So earlier menarche, higher risk of breast cancer over time. Delaying your first full-term pregnancy, not a good reason to have a kid. But women who have their first full-term pregnancy by age 18 have 1/3 the risk of women who wait until after age 30. Sorry, it's too late for most of you. So there are reasons why the incidence of breast cancer had been going, and there are probably environmental reasons that we don't really know. The point is that it had been going up steadily by 1 to 1.3% per year. Well, Blyer and Welch, and there are all these studies that have used those data in the past, and there are international data that show the same thing, that before there's any screening, the baseline was going up. So I'm just going to go quickly because I'm running out of time here. So I used the Connecticut Tumor Registry to go back to 1940 and extend the I used 1% here, but it's actually 1.3%, out to 2008, and look, if the baseline had continued to increase during the screening era, then the incidence of invasive cancer was actually lower than what you would have expected. There were fewer invasive cancers. Now, how could that possibly be true? Well, you've all been taking out DCIS, some of you for not too long, many of us for a long time. If DCIS is a precursor to invasive cancer and you remove it, there are going to be fewer invasive cancers. I can't prove that, but that would make complete sense. So not only were Blyer and Welch wrong, there was no excess of invasive cancers, there were fewer invasive cancers. And they misled the medical world and women by claiming all this overdiagnosis, and that's what's caused all the issues. And there have been multiple papers. Mine was one. Mark Helvey wrote another one. Dr. Etzioni did a third, all looking at the Blyer and Welch paper from different directions, and it's all wrong. And I don't have time now. I've used up my time. But there are still some more issues to bring up. One is when your doctors say, well, so the screening trials didn't affect all-cause mortality. All-cause mortality means death from any other cause. Now, in a treatment trial, like breast cancer treatment trial, you look at the deaths from breast cancer, but you also look for other deaths. Because, for example, in the radiation therapy trials, they realized that they were killing women because the coronary arteries were being damaged by radiation therapy. If they hadn't looked at all-cause mortality, they wouldn't have noticed that. In a screening trial, does anyone know what percent of women, of deaths each year in the United States are due to breast cancer? Anyone want to yell it out? 50%? 20? 3% of all-cause mortality in the U.S. due to breast cancer. That's still 40,000 women. 3% all-cause mortality. To do a randomized controlled trial to show a decrease in all-cause mortality in a screening population where most of the women are going to die of something else, you'd need 2.5 million women, and the trials, didn't even come close to that altogether. I think there were 600 and some odd thousand women total. So when someone says to you, well, it didn't do anything about all-cause mortality, the answer should be, if you don't know what you're talking about, you probably shouldn't talk about it. If you do the screening data the way a treatment trial would be, and you look at women with breast cancer in the screening, you remember everyone in a treatment trial has breast cancer. In a screening trial, you look at all the women with breast cancer, reducing deaths from breast cancer statistically significantly reduces all-cause mortality. So all the issues that have been thrown, the moles that have popped up or the Molotov cocktails that are coming from the truck in front of me, have all been shown to be nonsense. And as I say, there are more, and you can go through the talk if you could possibly stand it on your own computers. Any quick questions? Thank you for your attention. Everybody good? No questions? I'm happy to take them up here.